Hi everyone, and it's nice to meet you all. I'll try and be quick, and as Steve and Brian have said, I'm going to try and show you a bit of a live demo. But just to introduce myself to people that don't know me, first and foremost, I'm a clinician, a primary care clinician. I'm a GP, but I've also got lots of other roles for the ICB as an aging well steward and virtual hospital and data stuff for end of life and various other things. So I think since I've gained access to Athena a few months ago, I think it's been so helpful and powerful to see that there's so much valuable data that's now getting us closer towards a single point of truth. We are serving a population. We're not necessarily serving people who, we're not serving a heart or a lung. We're serving people that might have these conditions, and most people have multiples of these conditions. And it's those connected data sets from all our system and our providers and sources that Brian and Stephen have just shared that gives us a much truer picture of what's really going on and how we're driving. So as Stephen has highlighted, this isn't just looking at our performance, it can also become a really helpful research tool. And certainly myself and other aging well stewards that have been using this have used this to reveal things that we could never see before and can now prove with real data and evidence as a research tool to get far more intelligent with our data. So one of the things I've identified so far since I've started using it is that, it's getting us to a place where we can deliver more fit for purpose population health management that actually reflects the reality of our population, not the data gaps and the other way, that the outdated ways we had to measure data that wasn't able to tell the true story. And it's revealing inequalities and inequity that we could never see before. So those hidden inequities and inequalities, so that we can start to tackle that. And as I say, for quality improvement, really thinking about that quintuple value aim, value to person, population, system, workforce, etc., and helping us to identify what are our challenges, where is there unwarranted variation, planning our services, planning our workforce, and really helping us get to a much more sustainable, preventative, proactive approach, which is what NHS England is talking all about. And before I just demo the live Athena, I just want to highlight from an aging well stewardship perspective, which includes all adults living with frailty, dementia, or any adult with a life-limiting prognosis for any reason of any age. One of the biggest challenges we had is that this population is generating the lion's share of our demand. As you can see, this is real data from Athena in its early days, showing that disproportionate rise in activity for those three groups on the right, which is our aging well stewardship cohort. And the problem we had before was that the data we had wasn't fit for purpose. We weren't even measuring the things that could help us identify this population and also measure the things that we know deliver better outcomes for people. So we've been driving blind, and now, so we had to have better data performance tools that we needed to unlock this big challenge, which is as much a national challenge as it is local. But we're in a much better position now where we can start to see things that we could never see before. So I'm just going to quickly switch to Athena, and I'm just showing you from the very beginning. This is the landing page, and this is me logging in. And as Brian has shared, and Stephen, there's lots and lots and lots of different dashboards on here. So you can look at lots of things, the stewardship dashboards, other things. There's the model health system data, the sort of national stuff as well. But also there's the population health segmentation model, which is really exciting, because when we marry that up with other performance dashboards, you start to get that research and intelligence. So if I just quickly demonstrate to you, and I won't be able to show you all of these dashboards, but if I just show you the so I'm just searching, I'm just using the search function, because you can find dashboards that way as well. And this is the population segmentation model, which Brian will know I've been using a lot recently, because and it allows us to filter that data based on place. So these little blue, these sort of lines up here, not blue, black lines up here, these are the different filters that apply for each page. So, for example, I happen to work in South East Essex Alliance. If I just wanted to look at South East Essex Alliance, I could click on that filter and I could look at a particular age group, a particular practice population, a particular PCN, and I can filter by ethnicity and things. And as you can see, the numbers, they're changed. You can also look at particular population segments, so you can do that. And you can look at some of our highest needs segments, and you can look at various things that way. And the other thing is that as you get into the other tabs, you've got things like, as Brian described, you can look at our services utilisation across our different population segments. So you've got lots of different things you can look at. These are just 111 calls across the ICS, but you could look at ambulance calls. You could look at a particular segment. For example, let's just look at multimorbidity, and you could look at the number of ambulance calls and the rate for that population, or you could pick a much more complex population. This is our Aging Well Stewardship population here, and see how that changes. And as you can see, there's lots of things in here: community contacts, diagnostics, ED attendances, elective, non-elective, mental health admissions, primary care appointments, social care contacts, lots and lots and lots of different things that you can look at. And then in this tab, which is probably one of my favorites, in terms of the research capability that you can get from this, you can start to understand, also drilling down into different long-term conditions. So for example, let's just pick it, angina, and you can pick multiple conditions if you want to. So you can select multiples of conditions and just look at these conditions in combination, and you can see that the numbers will change. You can look at how that varies in a most deprived segment or a most affluent, and combinations of these if you want to. And then that starts to give you real intelligence about numbers of people that are living with multiple conditions, and look at the different demographics by a PCN. For example, I've just clicked on a PCN here and look at all the different age demographics, and then also look at things like wider determinants of health. So you've got risk factors here, not just clinical risk factors, but also non-clinical risk factors like alcohol misuse, for example, and how that looks. And I'm not going to show you all of the functions here, but it just sort of gives you a bit of a flavour about how you can start to play around to help you answer a question. And I'll show you in a minute in some of the slides about some of the questions that we've been asking it and some of the answers it's been giving us. So that's just an example of the population segmentation tool. But obviously, we've been building the Aging Well Stewardship dashboard. So if I just go to that one as well, no, age well, then it comes up there, and you can start to see the sorts of data that nobody could capture before. I think we're probably one of the first, maybe even in the country, that are capturing things like frailty scoring and CGA delivery on an all provider basis. So we're able to see those best practice inputs in a way that we never could before, and be able to see how that's looking across our different alliances and PCNs to identify where we need to keep getting better. And we've got end of life performance metrics in here as well. We've got hospital data. We've got discharge outcomes. We've got lots of different things in here, plus amongst all the other dashboards. I'm going to stop sharing my screen for the demo now, just to sort of demonstrate to you some of the answers that we've been getting out of here that's helped to identify some of our priorities. So for example, in the Aging Well dashboard, as I said, we're now able to measure the sorts of things that we never could before. And these are the things that make a difference to this population group. But we're also able to see variation. So for example, with our end of life population, this is an example of two different places in our ICS where you can see that the identification of people with end of life needs is much better in one place, plus it's happening a lot earlier in the day, and compared to another place where it's much lower, and a lot of that is late in the day. And then you can see the impact of those differences. So at high level, in terms of high level outcomes, so you can see this little locality which is doing better in terms of earlier recognition, more advanced care planning delivery. They have massively better outcomes in terms of much lower deaths in hospital, much lower repeated admissions in last 90 days of life. This is all our population deaths compared to this locality where the delivery of those sorts of metrics is a bit lower. So really identifying areas where you can prioritize that focus. And then, as I said, you can use it to ask questions. So we're very interested in looking at our population with a life-limiting prognosis and whether they're getting the best type of care and whether people are missing out. And there's a lot of myths out there that it's all about cancer and it's all about this and that. So we actually asked Athena the question by looking at the PHM tool, well, what are our commonest conditions who have the highest end of life needs? And as you can see, cancer only came down here, number 11 on the list. So really identifying that, these 3-4 groups at the top, which are often the hidden group that we're not always getting to, being a real priority, and actually showing the true light. How many people have a life-limiting prognosis? Not all of them will die this year, but they're at risk and they are needing that small personalised palliative care support. So 31,000 across the ICS. And then so really helping us to use that to drive QI. And then look at our real population with frailty and dementia needs. What is the number? Well, it's about 109,000 according to this. And what's the age demographic? Well, it's not all about older people. As you can see here, we've got about a third who are under the age of 65. And then looking at services utilisation for this particular group, where we can see the percentage in this group with ED attendances. We can see the percentages. This is all our mental health admissions to admission beds, including children, which was quite an eye-opener at showing the scale of how many are in that very complex group, frailty, dementia, and end of life. So what workforce skill sets do we need on those beds to provide better outcomes for these patients who have very complex needs? And then looking at particular long-term conditions, we know we've got strategies around cancer, around cardiovascular disease, but most people don't have just that condition in isolation. And this shows that common conditions that cluster together, like cardiovascular disease, renal conditions, diabetes, respiratory conditions, they tend to coalesce together. And this identifies the scale of that. 92% actually will have several of these conditions together, but they share common preventative interventions. So how can we get more intelligent with that? And yeah, so there's so many other things that you can see in this. We looked at alcohol misuse in the population, and that was revealing because it helped to sort of identify not just an issue in our most deprived population, affluence. Look at our most affluent population here. So those social drinking habits causing issues, and also in terms of our practices as well, prescribing practices like polypharmacy, which we know is a challenge, and you could look particularly at that, looking at the risk factor tool. As Stephen and Brian have shared, the Aging Well dashboard and the PHM dashboard is just one of very many, but we've got so many like the Better Care Fund dashboard, which I think is going to be really helpful to our local authority colleagues, and lots of indicators in that, and lots of our single long-term condition and other performance dashboards. I'm just showing here a screenshot of the cardiovascular disease ones and the targets around better blood pressure management and cancer screening performance, but also diabetes, weight management, and all of these other dashboards here. So just to sort of sum up, this is a way for us to get to a truer understanding of our current performance, but also seeing who are the groups of people that we're not reaching, that so that we can close that gap, so that we can really understand how we're really driving. And then the usefulness is across the board, whether it be for stewardship groups, for other ICS strategic transformation groups, place-based delivery, our frontline, all our providers, can use some of this information to start to sort of shape services development, QI, and actually sort of identifying any unwarranted variation, etc., etc. I can stop talking now because I've been talking for a while, but I'm happy to take some questions.